Member mic check, 1, 2, 3. Way back here, 1, 2, 3, 4, 5. Witness mic check, 1, 2, 3.
The Subcommittee on Civil Rights and Human Services will come to order. Welcome, everyone. I note that a quorum is present and apologize for the late start. We were voting. I ask unanimous consent that Mr. Langevin of Rhode Island be permitted to participate in today's hearing with the understanding that his questions will come only after all members of the Subcommittee on Civil Rights and Human Services on both sides of the aisle who are present have had an opportunity to question the witnesses. Without objection, so ordered. The committee is meeting today in a legislative hearing to hear testimony on strengthening prevention and treatment of child abuse and neglect. Pursuant to Committee Rule 7C, opening statements are limited to the chair and ranking member. This allows us to hear from our witnesses sooner and provide all members with adequate time to ask questions. I recognize myself now for the purpose of making an opening statement. We are here today to discuss our responsibility to protect the health and safety of our nation's children. Child abuse and neglect, collectively child maltreatment, are quiet nationwide tragedies that unfold every day in communities across the country. In 2017, state child protection services agencies received a total of 4.1 million referrals of possible child abuse or neglect, involving 7.5 million children. Altogether, child maltreatment affects as many as 1 in 7 children. Victims of child maltreatment typically suffer both immediate and lasting harm. In the short term, maltreatment can result in significant physical injuries in addition to emotional and psychological disruption, and the effects can last over a lifetime. Emotional and psychological abuse can hinder not only social growth, but also the physical growth of the brain itself. As adults, victims of child maltreatment can suffer from inhibited memory processing and struggle to control their emotions and behaviors. As a result, they are 7% more likely to drop out of high school and 9 times more likely to be involved with the juvenile justice system than their peers. The trauma suffered by these children and families will stay with them for a lifetime, and in Congress we should always look for ways to support trauma-informed care. In addition to the high personal costs, child maltreatment also carries devastating societal costs. Research shows that the long-term effects can have lifetime costs of more than $800,000 per child altogether. This is a public health crisis that costs more than $400 billion each year. Since the passage of the Child Abuse Prevention and Treatment Act, or CAPTA, more than 3 decades ago, we have made progress toward reducing cases of child maltreatment. In fact, from 1990 to 2009, rates steadily declined and then plateaued through 2012. Despite that, we face new challenges in our efforts to address child maltreatment. Since 2013, the rate at which children are abused and neglected has steadily increased, and with it, tragically, the rate of child deaths has also gone up. In the year 2017, child deaths from maltreatment reached an all-time high. 1,720 children lost their lives. Evidence suggests that the opioid crisis is giving rise to new challenges in protecting vulnerable children. In my home state of Oregon, I've met with parents, healthcare professionals, community leaders, veterans, and people from all walks of life who have shared heart-wrenching stories about how the opioid crisis is taking lives and inflicting pain on families. This crisis can be particularly devastating for mothers and newborn children. As our understanding of child abuse and neglect deepens, we must update our approach accordingly. We cannot continue to address this public health crisis by just reacting after child maltreatment cases arise. As this committee considers reauthorizing the Child Abuse Prevention and Treatment Act, last updated nearly a decade ago, we must shift our focus to preventing the maltreatment from occurring in the first place. We need a CAPTA reauthorization that strengthens federal investments in community-based prevention services so families across the country can receive help before children suffer. We need to build networks of wraparound services that lower the risk of child maltreatment by helping families navigate complex health, educational, and financial hardships. And we need to streamline communication between and among states so child protection agencies across the country can connect the dots and prevent cases of child maltreatment, no matter where they occur, from slipping through the cracks. All of us in this room recognize that Congress has a responsibility to protect children. We must work together to invest in services that prevent, not just treat, child abuse and neglect. Today's hearing is an important step toward making sure that all children grow up in a safe and healthy environment that allows them to reach their full potential. I want to thank all of our witnesses for being here today. I look forward to your testimony, and I now yield to the ranking member, Mr. Comer.
Thank you, Madam Chairman, for yielding. Thank you all for being here today. As the dad of 3 young children, today's topic is a very difficult one to discuss. No child should ever have to endure the pain of abuse or neglect by a parent or caregiver, and that's why today's hearing is so important. The Child Abuse Prevention and Treatment Act, or CAPTA, is the key federal legislation that helps states combat child abuse and neglect. This legislation, which was enacted in 1974, provides states with grant funding to develop programs aimed at prevention, assessment, investigation, prosecution, and treatment. The scope of this law is significant, and the number of children that are affected by abuse and neglect each year is staggering and absolutely heartbreaking. In 2016, Child Protective Services received over 4 million referrals involving 7.4 million children. Teachers, law enforcement, and social service professionals accounted for over half of all referrals. Of those 4 million reports, 2.2 million received a direct response from Child Protective Services. Of that number, approximately 676,000 children were determined to be victims of abuse or neglect. While neglect is notoriously more challenging to confirm, it still accounted for close to 75% of cases reported to CPS. And while we know that abuse can have serious lasting impacts on children well into the latter parts of their lives, research shows that the effects of neglect can be just as detrimental. In fact, some studies have shown that neglect can have an even greater impact on a child's healthy brain development. As this committee works to make CAPTA more effective in our fight against child abuse and neglect, our efforts should begin with prevention. Prevention takes a holistic approach to combating neglect and abuse by focusing on strengthening communities and educating parents and caregivers on how to keep children safe. CAPTA receives $158 million in annual appropriations, with $39.8 million designated specifically for community-based child abuse prevention formula grants, which support community-level organizations focused on preventing child abuse and neglect. In addition to bolstering our prevention efforts, this committee's work should streamline current assurances and requirements so states can focus on serving and providing treatment to children rather than spending more time filling out paperwork. State agencies benefit from increased flexibility that allows them to respond more swiftly and effectively to reports of abuse and neglect. We must equip states with the tools and resources needed to address maltreatment and keep kids safe. Children who have suffered abuse and neglect have unique needs, and it is our duty to ensure that they receive excellent care. I have no doubt that this subcommittee can lead this effort and champion bipartisan initiatives that strengthen CAPTA. I look forward to today's discussion about how we as a nation can effectively and compassionately serve these children. And I yield back.
Thank you very much, Mr. Comer, for your statement. Without objection, all other members who wish to insert written statements into the record may do so by submitting them to the committee clerk electronically in Microsoft Word format by 5 p.m. on April 8th. And I will now introduce the witnesses. Dr. Yo Jackson is a board-certified clinical child psychologist who studies the mechanisms of resilience for youth exposed to trauma. She is a professor at the University of Kansas and at Penn State University, where she also serves as the Associate Director of the Child Maltreatment Solutions. Over the last 20 years, Dr. Jackson has developed an extensive body of research focused on the mechanisms that foster resilience for youth exposed to trauma. Throughout her career, she has served and continues to serve as the principal investigator on several grants from the National Institutes of Health. And I'm going to skip over Ms. King temporarily because we're hoping that Dr. Schreier arrives to introduce Ms. King. Mr. Bradley Thomas has been the CEO of Triple P America since 2011. Triple P, Positive Parenting Program, is a system of evidence-based education and support for parents and caregivers of children and adolescents with a prevention focus. Prior to being appointed as CEO, he was involved in various capacities and working with public research organizations interested in transferring their research into the community. Following his work with research organizations, he accepted the position as CEO to focus on Triple P, which to date has been provided in over 25 countries. In that capacity, he has overseen the expansion of the program's utilization in the U.S. from 11 to 38 states. He has a law degree in Bachelor of Information Technology from Queensland University of Technology in Australia. Mrs. Lucretia Rose is a resident of Cabin Creek, West Virginia, where she is a loving wife and the mother of 3 children. Her own personal experiences with parenting have inspired her to be an advocate for all children and families. Mrs. Rose is here today to talk about her experience as a parent. Mrs. Rose is currently the facilitator of the West Virginia Circle of Parents Network, which comprises parent-led self-help groups that allow parents and caregivers to share ideas, celebrate successes, and address the challenges surrounding parenting. She's a former home visitor through the Parents as Teachers program and currently serves as a board member to her local program. Mrs. Rose is also active in her local community through volunteering with her local elementary school and youth sports. And I know Dr. Schreier wanted to introduce Ms. King, but I'm going to go ahead and do that. Ms. Judy King serves as the Director of Family Support Programs at the Washington State Department of Children, Youth, and Families. She has 30 years of experience in human services and family support and has worked at the community, state, and national levels. In her current role, she oversees work related to home visiting system development, child abuse prevention strategy, early intervention, therapeutic and trauma-informed child care, health and early childhood, and infant mental health. Ms. King also serves as the executive director of the Prevent Child Abuse America Washington State chapter and serves on the board of the National Alliance for Children's Trust and Prevention Funds. Oh, I just finished, Dr. Schreier. Welcome. Welcome to all of our witnesses. We appreciate all of you for being here today, and we look forward to your testimony. Let me remind the witnesses that we have read your written statements and they will appear in full in the hearing record. Pursuant to Committee Rule 7D and committee practice, each of you is asked to limit your oral presentation to a 5-minute summary of your written statement. Let me remind the witnesses that pursuant to Title 18 of the U.S. Code, Section 1001, it is illegal to knowingly and willfully falsify any statement, representation, writing, document, or material fact presented to Congress or otherwise conceal or cover up a material fact. Before you begin your testimony, please remember to press the button on the microphone in front of you so it will turn on and the members can hear you. As you speak, the light in front of you will turn green. After 4 minutes, the light will turn yellow to signal that you have 1 minute remaining. When the light turns red, your 5 minutes have expired, and we ask that you please wrap up. We'll let the entire panel make their presentations before we move to member questions. When answering a question, again, please remember to turn your microphone on. I first recognize Dr. Jackson.
Good afternoon, Madam Chair Bonamici, Ranking Member Comer, and members of the committee. My name is Dr. Yo Jackson, and I'm a professor of psychology as well as the Associate Director of the Child Maltreatment Solutions Network at Penn State University. I'm also a research professor at the University of Kansas, and I've worked for over 20 years as a board-certified clinical child psychologist and a researcher on the development of resilience for kids exposed to trauma and child maltreatment. Thank you for inviting me to speak with you today. Child maltreatment is a significant public health problem. In 2017, 7.5 million children were referred to protective services, with 3.5 million children meeting at least the minimum criteria to warrant an investigation. Of those, 674,000 children were determined to be victims of child maltreatment. That translates to a child being significantly harmed about every 45 seconds. Child maltreatment includes experiences like neglect, physical abuse, sexual abuse, with neglect being the most common. Sadly, 1,720 children died as a result of child maltreatment in 2017, placing the United States second only to Mexico for the most intentional child fatalities in the developed world. Child maltreatment is second in terms of the most prevalent childhood public health problems in the U.S., just after obesity and ahead of things like attention deficit disorder, asthma, cancer, and autism. In 2015, the average lifetime public cost associated with child maltreatment is estimated to be over $830,000 per victim, coming to a total of roughly $428 billion in costs for the number of victims over the course of just 1 year. Money that could have been saved if abuse and neglect were prevented. Maltreatment is associated with a plethora of negative and often devastating outcomes. It's important to note that most victims are under the age of 7, a time of great plasticity and the developing brain and social interaction systems. Early childhood is a sensitive period for the development of social relationships and forming secure attachments, something that is not possible in abusive and threatening caregiver-child relationships. Child maltreatment has serious negative consequences for brain development, impacting areas critical for learning, memory, emotion regulation, cognitive abilities, decision-making, and social skills. Beyond the grave neurological and biological effects, child maltreatment results in a lifetime of negative health behaviors, such as risky sexual behaviors, obesity, substance use disorders, chronic pain, and cardiovascular disease. Maltreatment is consistently associated with higher rates of all forms of mental health diagnoses, including risk for self-harm. Youth exposed to maltreatment are 5 times more likely than their peers to fail in school, to leave high school without a degree, to become a teen parent, to be consistently unemployed, to experience chronic physical and mental health problems in adulthood, and are 3 times more likely to be incarcerated, homeless, or live below the poverty line as adults. The range of emotional, behavioral, cognitive, and social delays as a result of child maltreatment are limitations that some may be able to adapt to, but most will never overcome. If adequate prevention programs were in place, these negative outcomes would not occur. Moreover, the negative effects of maltreatment are significantly increased with each re-victimization, making what was a hard-to-treat problem much worse and increasing the odds of long-term maladjustment. Given that on average, a child referred for protective services will be referred for abuse concerns 3 more times before they reach the age of 18, child maltreatment is likely underestimated in terms of its impact in the research presented here. The bulk of primary prevention efforts currently fall under the definition of home visiting, where professionals visit parents in their homes and focus on the well-being of children ages 0 to 5. Several of these primary prevention programs have been shown to reduce reports of child maltreatment. A paper in 2018 reported the cost, benefit, or return of $4 for every dollar spent on universal primary prevention programs. In contrast, targeted prevention includes a host of programs implemented within protective services to improve home environments and protect children from another instance of child maltreatment. A cost-benefit analysis found that 2 of the most widely lauded targeted programs, Safe Care, returned over $21, and Parent-Child Interaction Therapy returned over $15 in benefit for every dollar spent on implementation. Although child maltreatment is pervasive, it's also preventable. Because most victims of maltreatment are young children, prevention programs are critical to avoid the biological and social development impacts, impairments, and downstream effects. Child maltreatment requires a comprehensive prevention strategy. The reauthorization of CAPTA is an exceptional opportunity to better support the systems that protect children from maltreatment. Through CAPTA, we seek to better coordinate our efforts across the patchwork systems of federal, state, and local agencies and services, to seek out efficiencies and best practices that are supported by an evidence base. Data-driven approaches are necessary to increase the research base and to advance knowledge on what works for whom. We also need to seek to find and develop innovative coordinated solutions that facilitate the feasible and sustainable involvement of schools, parents, adults, government agencies, and service providers. Coordination, data focus, innovation. These frames are vitally important for prevention because what we know is that our current efforts have shown little to modest impacts. What we are doing now is not enough to stem the tide of child maltreatment.
Thank you for your testimony, Professor Jackson. I now recognize Ms. King for your testimony.
Good afternoon, Chair Bonamici, Ranking Member Comer, and members of the subcommittee. I appreciate the opportunity to speak to you today about community-based child abuse prevention, or CBCAP. I serve as the Director of Family Support Programs at Washington State's new Department of Children, Youth, and Families, and I'm the CBCAP State Lead in Washington. Thanks to CBCAP, Washington State served 1,698 parents and 2,153 children with family support services in 12 out of 39 counties last year. We still have a long way to go in reaching all of the children and families who could benefit from CBCAP services and systems building efforts, but that task would be difficult and less effective without CBCAP funding. Brain science tells us that laying a strong foundation early in life critically impacts healthy development. Science also tells us that addressing trauma at the individual, family, and community levels allows us to prevent bad things from happening, promote strengths in children and families, and intervene early. In our everyday work, this means we notice the important things. We identify the tremendous stress, pressure, and uncertainty that leaves parents feeling alone, unconnected, and ashamed. CBCAP is designed to create environments where families get the support they need before harm occurs. This supports children on a positive trajectory to reach their full potential in school and life. This work includes parental skills building, voluntary home visiting programs, self-help programs, coordination and connection with mental health and substance use services and other family supports. Prevention requires a highly integrated, multi-systemic public health approach. Just as we don't wait for someone to show signs of the flu before we encourage them to get a flu shot, we shouldn't wait for warning signs that a family needs support before making sure they have that support. In 2018, Washington's newest state agency formed, combining the strengths of an early learning department and child welfare services into one unified agency. A two-generation approach informed by brain science leverages CBCAP funding for families receiving TANF benefits to offer home visiting services and parenting education. Experiencing success in education, employment, and parenting can break the intergenerational cycle of poverty. We offer specific programs shown to be effective with tribal populations and are working extensively to build pathways for new moms to get the support that they need while experiencing perinatal mental health challenges like postpartum depression. These are a few examples of how my state uses its CBCAP funding. As a chapter of Prevent Child Abuse America and member of the National Alliance of Children's Trust Funds, I have a front row seat to witness the extraordinary work being done by my colleagues around the country and in each of your own states. The flexibility in CBCAP provides options for communities to implement evidence-based, evidence-informed, and promising practices. CBCAP awardees can tailor their programs to serve the needs of their communities while evaluating programs, measuring outcomes, meeting fidelity, and adhering to implementation science principles to achieve the positive child and family outcomes. States have said they need flexibility to use federal funds to help families sooner, before serious danger arises or harm occurs. As far as resources, CBCAP represents the main federal investment in primary prevention for the entire country, with an investment of $39 million over all 50 states in 2018. This funds prevention at 53 cents per child per year, resulting in a great deal of unmet need. The current funding in Washington state allows 10 to 12 local organizations to offer small-scale programs with more than 90% of qualified applicants turned away. DCYF, my agency, recently identified 23 small locales with highest rates of abuse or neglect that were not able to serve due to funding constraints. With more funding for prevention, we would work within each community to build community-driven interventions using a targeted universalism approach to increase services available in communities at known risk. This is prevention at its best, and it requires resources. The pursuit of the goal of strengthening families is through primary prevention, strong and responsive communities, and collaborative efforts among public health, early learning, and child welfare. Every parent wants to be a good parent. They just need the tools and supports to get them there. Families describe this work as raising their children with opportunities to achieve their hopes and dreams. I say it helps families live their best lives. I appreciate your time and attention this afternoon, and I'd be happy to answer any questions you may have. Thank you.
Thank you for your testimony. I now recognize Mr. Thomas for 5 minutes for your testimony.
Chairwoman Bonamici, Ranking Member Comer, and members of the subcommittee. My name is Brad Thomas, and for 8 years I have served as the CEO of Triple P America. I thank the committee for the opportunity to share my experience with the Positive Parenting Program, which takes a primary prevention approach to child abuse and neglect. In the 4 decades since CAPTA was first authorised, the US has built a foundation of child welfare and safety based upon best practices, evidence, and lessons learned. Systems can always strive to improve, and we are now in a position to build upon that foundation. We believe that the current system is under significant stress because it is designed primarily to provide intervention rather than focus on the prevention of abuse and neglect before it occurs. Costly systems have been built to deal with the conveyor belt of maltreatment, and therefore avoidable abuse and neglect of children occurs, the child welfare system is overwhelmed, and the taxpayer is faced with the resultant cost. There is a better way, primary prevention that targets the broader population. Notwithstanding the immediate and tragic impact of child maltreatment, it can also have long-term effects on health and well-being if not addressed. The treatment of child abuse and neglect after it occurs is significantly more expensive than the prevention of it. A study conducted by the Perryman Group estimated the lifetime impact of first-time child maltreatment occurring in 2014 as costing the US $5.9 trillion. Conversely, evidence-based models for primary prevention catch parents well ahead of adverse experiences for children. They normalise parents asking questions and ensure quick, reliable and actionable information. Oftentimes, this can be the difference between equipping parents with the confidence to problem-solve daily stresses or allowing stressful and challenging behaviours left unchecked to escalate for both parent and child. The challenge, however, is building systems that can scale and achieve reductions in child maltreatment at a county or state level. There are some essential elements that make programs like Triple P work to achieve population-level change. 1, program design. 2, evidence-based. 3, use of an existing workforce. And 4, cost-effectiveness. Let me explain. The most impactful programs to achieve population-level effects are designed to make services available for delivery in an array of settings that suit the parents' preferences and allow parents to receive help according to their needs, not taking a one-size-fits-all approach. Next, it is essential that programs and services are evidence-based. As an example, Triple P is the most researched parenting program in the world, with over 300 evaluation papers involving more than 400 academic institutions worldwide. One such evaluation was a landmark randomised control trial funded by the CDC in 18 counties in South Carolina in 2005. During the period studied, child maltreatment rates increased by 7.9% in the 9 control counties and decreased by 23.5% in the 9 counties where Triple P was implemented. Similar patterns were found for out-of-home placements and hospital-treated child maltreatment injuries. Training a community's existing workforce to deliver parenting supports dramatically increases the speed at which a program is able to scale and leverages existing trusted relationships between parents and providers. In turn, systems that only provide supports to the extent needed and utilise a workforce that is already in place saves money and resources. Independent research undertaken by the Washington State Institute for Public Policy on a range of programs supports these savings. By way of example, the research demonstrates that for every dollar invested in the Triple P system upstream, there is a resultant $10.05 in benefits downstream. In spite of proven outcomes, evidence-based models that align with primary prevention have been limited in their ability to scale due to a lack of available funding for prevention programs. CAPTA is the main federal legislation providing population-level primary prevention capacity building, so appropriate funding is absolutely critical. We applaud Congress for examining CAPTA and the prevention of child abuse and neglect generally. As Congress looks to reauthorise CAPTA, we encourage you to consider the following. First, a focus on primary prevention designed to reach the broad population will provide both monetary savings and reduce the human toll taken on children and families exposed to abuse and maltreatment. Second, the designation of appropriate lead agencies for CBCAP that have a demonstrated commitment to broad community prevention work, such as Children Trust chapters, Prevent Child Abuse chapters, and/or health departments, may help to unsilo streams of funding and have a more significant impact on communities. Finally, ensuring funding is allocated to evidence-based holistic primary prevention will thereby invert and shrink the funding pyramid over time and reduce the incidence of and costs associated with child maltreatment. I appreciate and welcome your committee's dedication to this important endeavour and stand ready to be of assistance in any and all ways possible.
Thank you for your testimony. And finally, Mrs. Rose, thank you so much for being here. I recognize you for 5 minutes for your testimony.
Thank you. Good afternoon, Madam Chair Bonamici, Ranking Member Comer, and members of the committee. And thank you for the invitation to be here today. My name is Lucretia Rose, and I live in Cabin Creek with my husband and 3 children. I'm employed by Team for West Virginia Children, where I facilitate a program with mutual self-help groups on the state level using the Circle of Parents model. And today I'd like to talk to you about why the reauthorization of the Child Abuse Prevention Treatment Act is important for families like mine. Have you ever found yourself wondering or wishing that someone would sit down with you and help you be a better parent? That's exactly how I felt when my husband and I found ourselves facing the same challenges that our parents had before us. And just like most first-time parents, you use the methods that were used on you as a child. And that didn't work for us. So the more I spanked my child, the worse his behavior became. One day I joined a local playgroup at the Sharon Dawes Elementary School through the Starting Points Family Resource Center right by our home. Talking with other parents made me feel like I wasn't alone, and I really enjoyed learning about my child's brain development. Eventually, I signed up for other programs through the Starting Point Center, such as the home visitation program with parents as teachers. And it was through building a trusting relationship with my home visitor that allowed me to reach out for help with my concerns surrounding discipline. My home visitor was wonderful. She provided me with tons of positive parenting solutions, such as time in versus time out, getting down to my son's level and looking him in the eye. She encouraged me to look at these tools as like a tools in a toolbox. And some of the concepts were so simple, but yet they never crossed my mind. Maybe that's because the only tool I ever had in my toolbox was a hammer, so everything looked like a nail. A couple months later, I was at a group exercise for the Circle of Parents, and I had to play the role of a parent who'd lost her child due to harsh physical punishment. And this hit me like a ton of bricks, because the only difference between that parent's outcome and my own was prevention. This sparked a fire inside of me and made me realize that I needed to pay it forward. And so I started to climb the parent leadership ladder. I became a home visitor for the Parents as Teachers program in my local community. And then I started to facilitate the Circle of Parents groups at a state level. And then I was invited to become the co-chair of the Alliance National Parent Partnership Council. But my favorite achievement on my journey was becoming certified to deliver the same program that saved my life. The Strengthening Families Protective Factor framework of bringing the framework to life in your work. This snowball effect has led me here today. Growing up, my parents worked very hard, but yet struggled to provide my brother and I with the best life that they could. And today, families continue to struggle, but local prevention programs help families like mine succeed. Prevention matters, and it can be used in all families. So here are my hopes. I hope that something I've said here today helps you recognize the importance of increasing the resources that are available to families. Currently, Congress invests about 53 cents per child annually across the nation. We can do so much better. It would be great if we could increase that to 53 cents per child per month versus annually. I hope that you hear more testimonies in the future with happy endings like mine, due to the efforts of prevention that you have created and supported. And I hope that one day my children will be able to stand here in front of you and thank you for listening to their mother's story and tell you about the lives of their children and how much richer they are because of the decisions you make in the next coming days. Thank you for your time here today and letting me tell you what I believe helps build strong families, yours, mine, and all families across the nation.
Thank you very much for your testimony. What a wonderful example of how you can break the cycle, and we really appreciate your being here and sharing your own personal story. Under Committee Rule 8A, we will now question witnesses under the 5-minute rule. As chair, I will start and be followed by the ranking member, and then we will alternate between the parties. Ms. King, thank you for discussing the importance of the federal community-based child abuse prevention grants and your agency's prevention work in Washington State, my neighbor to the north. We know that child abuse and neglect is preventable, and yet, as you mentioned in your testimony, the grants are currently funded at half of the federal authorization cap. In my home state of Oregon, the CB cap grants are critical to supporting key prevention activities. In the fiscal year 2018, we got $280,000. That's it. That's not nearly enough to meet the needs. So can you talk about how increased federal investment in the CB cap grants would benefit your state's work and the work of other states on prevention?
Sure, thank you. It's an interesting experience for us because we provide very small grants for small-scale programs with our CB cap funding. Approximately $30,000 to $40,000 per program that's involved for a 3-year cycle. We end up only funding 3 to 4 new programs per year, with usually asks coming in from communities for between $800,000 and $1 million. So just the nature of communities that are ready to be implementing services, see needs in their community, have models that are going to work, we see a tremendous need. We also, I discussed briefly that we have identified 23 locales, think about a little larger than a neighborhood, but not as large as a sub-county, that really have some of the highest risk. And what we'd like to do in the future is figure out how to embed more programs and services, not just prevention, but early learning and other types of support services in those communities driven by the community. And that's something to do that deeper work we can't do with current funding as well. So I would say we have a lot of unmet need and a lot of communities ready to take action.
Indeed. Thank you so much. I mentioned in my opening statement the opioid crisis, and I'm very concerned about the increase in the rate of child abuse and neglect, and some of it, we have it in conjunction with conversations about the opioid crisis. I remember in Oregon, listening to the story of a woman who became addicted to opioids. They were prescribed to her following a C-section. And then when she ran out of her prescription, went to the streets, lost her kids for a while, and it was hard work to get them back. And I've seen, so we hear tragic stories like that across the country, but I've seen promising programs to support these families. For example, Health Share of Oregon, a coordinated care organization in Portland, provides integrated care for mothers with addiction and their children, some of whom are born with withdrawal symptoms, and another program called Project Nurture that supports families during their pregnancy for a year, and then after the child is born. They receive substance abuse treatment, mental health services, and parenting resources. And the majority of mothers who have participated in the program are now parenting successfully. So what more can be done at the federal level to address this increase in child abuse and neglect that's exacerbated by the opioid crisis and support those families? I think I'll start with Professor Jackson, if you have thoughts on that.
I think it's really important to remember that this is an issue that has multi-sides to it, that child abuse and neglect is not caused by one thing. There's not one situation that we can point to that will tell us every time what's going to happen next. And so we have to be vigilant about what the data tells us. So I think what I would encourage you to think about is really the multifaceted nature of the factors that contribute ultimately to this happening, and then and part of why we have to think about prevention in a multi-pronged way as well.
Thank you. Does anybody else have thoughts on especially the mothers, keeping them with their kids? What's the best way to address that? Ms. King?
I would agree with Professor Jackson. I think it's a very complex problem, and it requires a complex set of solutions across those many partners. your suggestion of the work in Oregon with really embedded in coordinated care on the health side, also being really supported through where dollars flow for substance use and mental health treatment, and child welfare and early learning, all having a response to this. What we know is that it's some of our youngest children, infants in our state, and I know many other states are the highest percentage of children coming into the child welfare system, with a high degree of those children coming in due to substance use. And we have to look at how we can work together across the system to provide more opportunities for families. I've had a story shared relatively recently about a family who was receiving home visiting services, hadn't screened in the questionnaire for using substances, and got to the point in her comfort level with a home visitor to say, "I'm afraid that my baby will be affected when it's born." And that home visitor then was able to work with that mom to do some planning, let go of some of the shame and guilt, and try to help her be successful.
Thank
So
you. I don't mean to
think
cut you off, but I want to set a good example because I'm over time, so yield back. Thank you. I now recognize Representative Stefanik from New York for her questions.
Thank you, Chairwoman Bonamici. I also want to thank all of the witnesses for your very important and compelling testimony today. I wanted to particularly highlight your testimony, Mrs. Rose. Thank you so much for being here. Your statement was incredibly powerful to hear from you as a mom, and you are an example for so many parents across this country. So thanks for your courage today and for telling your story. I wanted to ask the panel as a whole, and anyone can answer. The data shows that neglect is the most prominent form of abuse cases. Can you talk about the different ways children are neglected that may not be obvious to viewers today or people at this hearing? And then specifically, how we can structure programs to help prevent these cases of neglect. So first, the indicators of neglect, descriptions of examples of neglect, and then broadly, how we prevent neglect. Professor Jackson, I'll start with you.
Sure. So there's a couple of different ways when we think about neglect. That actually covers several different things. So it includes things like personal hygiene, physical hygiene. It includes health, so taking your child to the doctor when they need to go to the doctor. It also includes things like educational neglect, which is making sure your child goes to school. So there's a variety of different things. Some of them are very clear from the outside. So kids who show up to school who haven't changed clothes, for example. But sometimes things are harder to see, right? So in terms of the neglect in the home environment, right? Sometimes those are basic needs kinds of things. Is there enough food, right? Things that a caseworker maybe could easily spot. But there's other types of neglect that are, I think, to your point, more challenging to see because they're not so obvious and physical, right? So that might be more things like emotional neglect, right? Where you're not providing support, emotional support, praises, and encouragements to your child for the things that they do. Children need that. That's not extra. Children need your support. They need your praise. And so what prevention efforts do in terms of addressing some of those harder to see everyday things is they provide parents with education. They provide them with support of their own so that they have the capacity to be able to support their children emotionally and socially as they move forward.
Thank you. Mr. Thomas, did you want to comment on how your program invests in preventative measures when it comes to preventing neglect?
Sure, and I think Professor Jackson handled that really nicely in terms of the answer. I think the emotional neglect is certainly one that is not as obvious. And a large part of what Triple P does is simply to get a parent to enjoy parenting again and to build a stronger relationship with their child. And there are strategies such as praise that Professor Jackson mentioned, and getting involved in activities with the child to have that relationship and build that relationship with the child.
One follow-up, and this may fall under the educational focus that you talked about, Professor Jackson. One of the challenges we have in the 21st century is screen time. Can you talk about whether we have invested in parenting classes or information on how technology, specifically regarding the regular use of screen time to keep kids occupied, can potentially lead to harm down the road? Professor Jackson.
So the short answer is yes. There's a whole area of burgeoning research on what screen time is doing and how that operates in the growing and developing brain of children, what ages children should have screens when they shouldn't have screens. appreciating too that they have screens in schools, right? So that's actually, there's a good side of this, right? You see kindergartners learning faster, you see kids who demonstrate symptoms of autism able to communicate better, right? So we talk about screen time, we're not always talking about video games, I think, which is what a lot of times that means when children are sort of babysat by the screen, right? But suffice it to say, there's a growing area of research clearly pointing out what some of the negative effects can be in terms of the reduced capacity to pay attention, reduced capacity to be frustrated, it challenges with listening and being able to follow complex commands. But this is a growing area because clearly screens are everywhere. They're not something that we see in just the home or maybe just as a toy or an activity.
And just in my remaining 30 seconds, I think it's important when we talk about educational tools for parents that we provide information about screen time and potential long-term negative impacts of too much screen time at an early age. So thank you very much again for the testimony and for answering my questions.
Thank you. I now recognize Representative Trone from Maryland for 5 minutes for your questions.
Good afternoon, and thank you again for your testimony, Mrs. Rose. That was really important, and the numbers are very sobering. There's no question about it. The enactment of the Protect Our Kids Act in January of 2013 established the Commission to eliminate child abuse and neglect fatalities. It called on the Commission to produce a national strategy and recommendations for eliminating fatalities across the country. Chairwoman Bonamici, I'd like to submit the final report. Within our reach, a national strategy to eliminate child abuse and neglect fatalities. For your approval into the record. Thank you. Dr. Jackson, the Commission recommended the federal government create national uniform definitions for counting child abuse and neglect fatalities and life-threatening injuries. In my state of Maryland, we recognize the value of comprehensive data and have integrated steps into our system, such as working with child fatality review teams, Office of Chief Medical Examiners, et cetera. Can you talk and speak to a little bit about the importance of standardized data nationally?
So as a researcher, that's something that's really important to me. So I think the simplest way to explain it is that you can't further knowledge if we don't all agree on what the definition of it is. Right? So we all have to agree on what it is, and then we can move forward with studying it, right? Whatever that might be. In this case, a very, very serious topic, a critical topic, to better understand the rates, prevalence, incidence rates of child fatalities in the country, especially those related to child maltreatment. So that seems almost without question to be a critically important next step for folks to have a universal definition. If you don't have a universal definition, if we don't all agree on what that is, then we can't further our knowledge. Moreover, we can't understand why these things happen. We don't know what leads up to them because there's a myriad of things included in the pool. So it's important for us, if we actually want to create interventions, right, or prevention interventions that speak to reducing those numbers, that everyone be operating out of the same definition.
Thank you. Last year, Congress dedicated an entire section in the Support for Patients and Communities Act to trauma-informed care. This section affirmed the importance of preventing opioid addiction. In my district the other day, over 25% of the babies born had opioids or alcohol in their bloodstream. 4% were born addicted. It's mind-boggling. So this importance of preventing this report will address a key element that often underlies substance abuse and the harm caused by childhood trauma. This week, we're sending a letter to the bipartisan coalition of members to the Appropriations Committee to support funding for these provisions. I hope we can continue to invest in tools to identify, understand, and address and mitigate the effects of trauma on children and families. But Mrs. King, in your written testimony, you mentioned to prevent childhood maltreatment, we must put science into action. Research tells by the age of 3, 80% of the brain is done developing. So laying a strong foundation early in life is important. Could you address the importance of addressing trauma in individual, family, and community levels, and how we have to have family-serving systems be trauma-informed?
Yes, I can. I think for us, especially on the early learning side of the spectrum, again, during that critical time of brain development and the critical time where children learn that their needs can be met by a caregiver, that we look at all of the places that those children and family interact with and make sure we have standards for what that looks like to both be trauma-informed and also healing-focused. We'd like to look at what our settings and environments are doing to promote healing among parents and children. One of the key strategies that has been used and is being implemented in a lot of states is building trauma-informed care in child care and early learning settings. So we have child care providers that understand when a child comes in and is struggling and having a hard day, that it's not aimed at the teacher, it's not aimed at the child care provider, it's the child working on trying to regulate their emotions and deal with some things that are happening with them. It helps us with thinking about how we can build that capacity in our full system so that the places that those children are during the day, they get that positive experience and build relationships with trusting adults.
Thank you.
Thank you. I now recognize the ranking member of the full committee, Dr. Fox from North Carolina, for 5 minutes for your questions.
Thank you, Chairwoman Bonamici, and I want to thank our panelists for being here today. Mr. Thomas, when you talk about saving $10 on the back end for every $1 spent on the front end, are those real dollars? And is it the federal, local, or state government that's reaping the benefit?
Because the issue of child maltreatment cuts across so many different agencies, the benefits that flow from the investment in evidence-based programs cut across local, state, and federal funding streams. You also see in those benefits, some of those benefits also go to the participants as well, and also the taxpayer. But it is spread across all of those different systems, such as child welfare, justice, and education, as some examples.
Thank you. Mr. Thomas, why is it important for state and local governments to think about where these kinds of programs are housed within their systems?
In the case of programs like Triple P that are focused on primary prevention, it's critical to have a fit within an agency that has as its mandate a focus on the broader population. And so it's important when assessing the best fit for these programs as to what is the best agency to actually deliver or at least oversee the delivery of these programs into the community to make sure that they can scale up effectively and reach the broad population.
Thank you. Pardon me, I have another question. Mr. Thomas, I believe collaboration across stakeholders is critical if any program is going to be successful in addressing the issue attempting to be solved. What kind of collaboration do you do in your program to know you understand the key triggers of abuse?
You're absolutely right. Collaboration amongst the various stakeholders within a state system is, or a county system is critical. That if you're going to scale up a program at a population level, you need to have all of the entities involved with parents involved in that process. And so we actually spend a lot of time when we go into a community identifying what systems are in place and making sure that we bring those people along to participate in the process of bringing the program to all of those various systems and to the general population.
Thank you. I want to say to the panelists that some of us were going in and out, and I apologize for that, but we had another committee down the hall that was having votes, and unfortunately we had to run down and vote and then come back. So I apologize for having been out of the hearing for some time, but that was the problem. Thank you again for being here.
Thank you. I now recognize Representative Hayes from Connecticut for 5 minutes for your questions.
Thank you, Madam Chair, and also thank you, Representative Fox, for just the explanation that the committee, I apologize for coming in late, and I also want to thank the witnesses for being here and for your tireless work on this very issue of child abuse and neglect. I spent the majority of my adult life as a teacher. In fact, before coming to Congress, I was a classroom teacher, a mandated reporter, so I know exactly what you're talking about. And as some of my colleagues have expressed, I also recognize that abuse is not always blatant. You know, for me, it was neglect was more of a factor, you know, and understanding and recognizing what that meant and what that looked like. And in my community, in the city of Waterbury, where I taught, generally that was associated with addiction and trauma from addiction that really reverberated out into the entire family. In Waterbury, Connecticut, where I was a teacher, last year we had 85 opioid-related deaths. And in most of those families, there are children who are coming to school and they don't have a label that says, you know, my mom is an addict, or no one at home is feeding me, or my dad is in prison. And so a lot of this, it was up to the educator to have an appreciation and understanding of what they were seeing and, you know, what their responsibility was in that. This is something that was very important to me because I was one of those kids. I grew up in a home like that. And I guess what I want to make sure, and Ms. Jackson, my question is for you, being that we know that poverty is a risk for many of these young people, addiction is a risk, when we're responding to referrals for child maltreatment, how can we assure that we're addressing the underlying issues and not simply separating parents from children because they're poor or they don't have the background or the information they need?
Right. So I think that's a really important question because a lot of research that's been done through the years, especially in the early years of identifying child maltreatment, looked for correlates, right? Things that seem to be associated with abuse. What do these abused children and these abusive families have in common? Science has evolved tremendously since those early days, but some of the early findings are still with us, right, in terms of trying to clarify really what the active factors are. So to be clear, we are much better now in our place in our science of knowing what are the causal factors for child maltreatment. We're very clear about those things. What we notice about those families is that they have several things in common with each other. They're not always identical, but they have several things in common. There usually is a significant difficulty in support in those families, maybe some challenges with mental illness in the parents, maybe a tremendous amount of stress in the family, maybe there's a tremendous amount of conflict in the family. Lots of different things that we could point to that are active causal factors for child maltreatment. Poverty is not one of them. Okay, so I get that that's where, in the beginning, the thing that seemed to tie a lot of people together, right? But that actually isn't a factor that is an active ingredient in risk for child maltreatment. It's really the host of many other things that we know very well that contribute. So what prevention does is it speaks to those things. It speaks to the things that the science tells us actually make a difference. Right? Those things that are actually important in affecting change. The anecdotes we see a lot of still to this very day, but as a scientist, what I'm most interested in are the efforts that the prevention makes to tie to this, to what we know actually makes a difference. So prevention will tie to things like education and conflict resolution and giving support and resources to those families, regardless of economic background.
Thank you. I so appreciate you saying that. Ms. King, my next question is for you. Based on what we're talking about, how can we better prepare teachers and mandated reporters to ensure that bias is not a contributing factor when they are looking for signs and symptoms of abuse or neglect? I've seen many young people who come from families who did not have a lot of money, you know, who lived in poverty, but there was an abundance of love, and parents were doing the best they could, and someone from the outside looking in at that might not see the same thing that I saw or be able to identify that this was a caring and supportive family. So how do we ensure that our teachers, our mandated reporters, the people on the receiving end of this information don't let their own biases get in the way?
Well, I think you nailed it very carefully about the disproportionality that we see in our system. And I think that's an ongoing struggle. It's an ongoing struggle in education for teachers. It's an ongoing struggle in early learning. And in reality, it's an ongoing struggle in child welfare as well. I picked up on your comment at the beginning. Thank goodness children aren't wearing the label about what they have going on at home, because we want our educators, the trusted adults that work with children, to see the strength, see their resiliency, And we want our network of the multidisciplinary approach to child well-being to respond looking at strengths. That's the important piece, and I think that's where I see a paradigm shift happening in prevention, is we're looking at strengths to build strong families. We have to focus on harm when it's occurred, but if we're looking upstream, we're looking at building strengths in families.
Thank you. I now recognize the ranking member, Mr. Comer from Kentucky, for 5 minutes for your questions.
Thank you. Mr. Thomas, I appreciated your testimony about the insight about the principles that guide your organization. What are some key aspects of your program that could be used by other entities to attain the success that you have seen?
I think some of the discussion previous to this focuses on that, and it's this: you don't know where child abuse is necessarily, and you can't make assumptions. And so one of the elements that makes Triple P successful is that it reaches the broad population, and that way you know that you're covering families that need the services. But also, using an existing workforce enables us to scale up very quickly, and also it leverages off that trusted relationship that is already there, say with a primary care provider or a school teacher, and enables that advice to be given in a trusted relationship.
Okay. This next question will be for all four members of the panel. What's working now with CAPTA and what is not? Briefly. Mr. Thomas, do you want to start?
Yeah, I think there's it's sometimes difficult for agencies that have a mandate to provide services to a specific population to also then juggle primary prevention, which takes it outside of the narrow population that they're serving and requires a focus on the general population. So where we've seen it work very well is where CB CAP monies have flowed to Children's Trust, for example, in South Carolina, where they've used CB CAP money there to expand on some Triple P work and other things as well. And because they have that broader population level focus, that's where we've seen it work exceptionally well.
Ms. King, would you like to add anything?
Yeah, I will add. I think I appreciate Mr. Thomas's comments on that, because I think what we have to do is get out of the space where we're only thinking about direct services to that more coordinated system, and the systemic efforts that we really need to have to build relationships with existing providers, existing partners that work with families, to have that message carried out in all kinds of ways. We know that one message alone typically isn't enough. Things like safe sleep practices that we're working really hard on across states because we want to prevent fatalities related to unsafe sleep. We know that message needs to be embedded by lots of folks, many times, different ways, to be able to ensure that we have children sleeping in a safe way. So we'll use that with primary care, we use it with child welfare staff, we use it with social network messaging among families, sharing that information, because those are the ways that we embed it in more of a system. Okay. So moving from individual programs to more of a system would be one of my recommendations.
Thank you. Professor Jackson.
I would agree with that as well. What we really need is this integration. I think that it's the patchwork that we struggle with so much day to day, from one state to the other or one agency to the other within the same sort of community. There's not a great deal of communication about these things. So that's another part of the frustration, is that when there are things that work well, it's actually very difficult to let a large proportion of folks who'd be interested know about that in a way that they can receive it. So that's one of my recommendations as well, as we think about integration, coordination, and making sure we have a vehicle, a mechanism that's an easy vehicle or mechanism for communication.
Thank you. Ms. Rose?
So, like they have said as well, is relationships, and not only building a relationship with the family, but treating the entire family, because children grow up in families and families grow up in communities. And so to treat the whole family, and I mean from one generation to the next, treating that as a whole and providing that consistent messaging that children are exposed to. For example, my in-laws and my parents being able to sit in on our home visits and learn the same language and the same methods ensures that no matter what environment my children are in, they have the same language, they have the same methods, and the same with our local schools. And you can just go build. But so I think the consistent messaging and relationships as a whole, treat the whole family.
Thank you all very much. Now yield back.
Thank you. I now recognize Dr. Schreier from Washington for 5 minutes with your questions.
Thank you, Madam Chairwoman. First, Mrs. Rose, I just want to thank you so much for sharing your story, because you have personalized your story for all of us. I think I'm a pediatrician, and I still found parenting to be a challenge, and so I think we all understand how important the job is and how little training we get for it, and it's the most important job of our lives, so thank you. Ms. King, I'm sorry I was not here to introduce you. My question is for you. As the lead CBCAP entity in Washington, you're the primary funder of child abuse and neglect prevention programs in our state. And in your testimony, you talked about a coaching program for parents, and then you also mentioned a two-generation approach. And I was wondering if you could talk about this coaching program for positive discipline and what the interaction looks like between the coach and the parents, between the parents and the children. And then we'll see if I have time for another question.
Thank you. Yeah, we like to use the word parent coaching because sometimes if we use the word parent visitor or parent educator, people view it as top-down messaging, and really coaching the parent has to do with the interaction between the parent and child that someone's helping to support. So yes, there's pieces that have to do with knowledge, but it's actually a lot about attitudes, skills, and behavior. So if you were working with a program that focuses on infants, you'd expect that coach to work a lot on attachment issues. That serve and return tennis term about a child making some communication and a parent being able to respond, starting that very early brain development. For toddlers, I would say one of the most typical things we see with parent coaches is trying to understand what's expected of a toddler, where they are developmentally. They just can't share right away. And working with toddlers on again, regulating emotions, being able to have words for feelings, and for parents not to get triggered. So developing that capacity in parents to be calm and be able to address what's going on with their child. So the coaching really is about side-by-side work, noticing the strengths, and building on those.
Does the coach in these interactions, I'm imagining them at a family's home, watching the interaction between the parents, do they model it at the same time? Do they check in afterwards and say, here's what I observed, try this next time? All of the above?
Yes, I think they can. I think a lot of our programs are really trying to focus on seeing what the parent's already doing and help the parent notice that. Again, with that notion that looking at strengths. But there's lots of side-by-side coaching because a parent, wants a do-over. They got worked up and it was hard for them to deal with something with the child, and to be able to say, that's okay. Let's think about how you could try that the next time. So I think we get some of both, but again, sort of scaffolding. Sometimes it's about how a parent's experiencing their child, and sometimes it's actually about skills and behaviors that a parent needs to practice to work with a particular age.
Have you seen, even maybe within a family, a difference in outcomes, kindergarten readiness, later success in life between, say, the first or second child that didn't have, or the parent didn't have this kind of coaching, and then subsequent children where they did have this kind of coaching, and what that meant for a family long term?
I probably can't speak to research on that. I do know what we hear from families where they say, wow, if I only had known this with the first child, because they may not have found that trusted partner or that appropriate service when they had their first child, and the second child comes around, and there's this notion of, wow, it would have been a lot easier if only I had known. I don't actually know if we have any research or data that's showing different outcomes by
I have another
there any
question that
que-
you might have an easier answer to. So you said you've only been able to serve 12 out of 39 counties, and I was wondering if you had more resources. Can you tell me where you would put them, either which counties or which sorts of programs expanding to different areas?
Well, it's interesting. We're sort of in a unique place. I think there's a commitment to evidence-based models, and there's also really a commitment to working in communities with changing demographics and building evidence for things that have been shown to be effective in a community. So we have 23 we've identified in this analysis, and we would really like to begin that work, planning with those communities with the solutions that they want to best meet the needs of their families. Not us choosing the model or approach, but really having the community look at what's available to match for their needs.
Thank you very much.
Thank you. I now recognize Representative Johnson from South Dakota for 5 minutes for your questions.
Thank you very much, Madam Chair. Mr. Thomas, for almost a decade, I was on the board of directors of Abbott House, which is a home for abused and neglected girls in my hometown of Mitchell. So I've seen the cost in human terms, as well as dollars and cents, in dealing in providing a therapeutic-based approach. And so I was connected very deeply with your conversation about the importance of prevention as opposed to just treatment. And I thought the outcomes, the data from your program was really impressive, some of the things you mentioned. You mentioned that it was widespread deployment. I mean, give me some sense of how widespread.
You mean in terms of throughout the US?
Yes.
Yeah. So we've trained in over 38 states in the US, and one of the states that I'd like to highlight in terms of really scaling up within the state is in North Carolina, where there's at the moment services being delivered in between 40 and 50 counties with plans to scale up to the full 100 counties within the next year or two. And so programs like Triple P are built and designed to scale.
You mentioned in your testimony having some, a flexible and tailored approach. I would think that would make it more difficult to scale up. Not the case?
No, it's the planning of it is the critical part. And so when you go into a community, you need to work out where because there are a variety of approaches from light touch intervention through to more intensive services, you need to identify where the parents are that are likely to need to receive those services, and then you engage with those groups and train those people. So we've invested heavily in implementation science to understand how best to roll out a evidence-based program. The trial data always shows that a program works. The next challenge you've got then is how do you then take that and make that work within a community? And that's where the field of implementation science has taught valuable lessons in terms of how to scale up.
And you talked about using existing labor, existing professionals, which I agree seems like it would make it much easier to scale up. I mean, when I talk to these people out in the real world, they all, without an exception, describe how full their jobs already are, how complete the demands of their profession are. I mean, how do you clear space for those people to deploy yet another intervention?
Often it's a case of it's not adding on to what they do. It's a case of, particularly, I'll use an example of a pediatrician. They'll quite often get asked questions that are not health related. They'll get asked questions that are behavioral related or developmental related. And so a lot of the time they struggle to know how to actually answer that question in an evidence-based manner. And so it's not adding to the job, but it's giving them the tools to do their job in a better way.
And I don't know a lot about your curriculum or your approach, although what you described in your written testimony and verbally made a ton of sense to me. I mean, having parents engaged and playing with and experiencing things with their children. When I do that as a father, I feel far more connected with my children. I would assume that's a message that needs to be reinforced on a regular basis with parents so that it really sticks. Is that demanding too much of someone like a pediatrician?
No, because when you roll out a program like Triple P, the idea is to have multiple touch points within a community. I think that was mentioned before, that the more the message is heard, the more the messages are reinforced. So if you embed a program like Triple P within a community, you'll be getting similar messaging from a teacher, from a pediatrician, or a place of worship. And so when the parent is consistently exposed to that, part of what we also do is a communications strategy. And that's a large part of the program where there are messages either on the internet or radio, TV, posters, flyers, that really destigmatise the need for parenting supports and normalise that process for asking for assistance, and also as another touch point for providing assistance.
So the data suggests that what you're describing works well. Is there anything within CAPTA or other federal regulations or programs that makes it more difficult for your program to scale up and help more people?
No, I think the evidence we've seen is that the CBCAP monies that have flown to the agencies that have rolled out Triple P, it's worked well in that regard.
Thank you very much. Thank you, Madam Chair.
Thank you, and I now recognize the chairman of the full committee, Representative Scott from Virginia, for 5 minutes for your questions.
Thank you, Madam Chair. Mr. Thomas, you were asked about real numbers on prevention, and one of the problems with prevention generally is that the person funding the prevention program isn't going to be the one reaping the benefits. You have the city could fund a nice summer program, intensive enrichment program in a community. The benefits are going to be reduced incarceration and social services to some other agencies down the way. And that's just the way it is. But if a case goes bad and it costs $1 million, it seems to me that somewhere along the lines we should have figured out how to prevent it if we could. You talked about the primary community prevention generally, as opposed to trying to target the prevention to a small group. Can you say that, you just said a little bit about it. Can you say why it's important to be community-wide and not try to target it?
Sure. Firstly, it's thought that there's more, it's more likely that there's 40 times more abuse occurring than is actually reported. And so even if you try a targeted approach, you don't know where that abuse is occurring. And so a broader approach is critical for that reason. But also, even what you would consider typically well-resourced parents are also susceptible to abuse. And there can be triggers within any household that can lead to that abuse and neglect. And so the other issue with targeting specific populations is that you start to stigmatise those families and the program as well when you target families in that fashion when you're having a primary prevention focus. And so the idea is to make it widely available in order to really address child maltreatment rates.
Thank you. Dr. Jackson, I guess one question people would have is, does prevention actually work? Are you familiar with the Nurse-Family Partnership Program?
Yes, I am.
Has that been studied, and can you say a word about the results of those studies?
Sure. The Nurse Family Program is probably one of the oldest programs. One of the first ideas was to have the paraprofessionals or have nurses or have other types of professionals come in the house, come meet with the family and help you in the house, really starting prenatally in lots of cases, right? So with pregnant, what might be considered high-risk families, and to prepare that family for the arrival of the child and then to work with them after they left. It has the most evidence, perhaps because it's been around the longest. It's also been evaluated tremendously, but we find that that's considered to be an evidence-based program at the highest level of rigor, that we have a metric for evidence.
And what is it? Does it reduce child abuse?
Well, it reduces child abuse reports. The evidence also speaks to fewer hospitalizations, bearing in mind, too, that child abuse is several different kinds of things. Primarily what we find...
Does it reduce long-term, does it reduce prisons?
Well, I think that's a hard connection to make for anything. Long-term, reducing time in prison. What we find more immediately is fewer juvenile justice problems, right? Fewer conflicts in the homes.
Currently, each state uses its own child abuse and neglect registry to collect information, which means if somebody has a problem in Oregon and moves to Virginia, Virginia may not know. Would creating a mechanism that allows states to share data of their child abuse and neglect registries help other states avoid problems? Ms. Jackson,
So-
Professor Jackson.
So this is a vital next step, that states be able to speak to each other. It may surprise some members of the committee to understand that actually every state has its own system and that they don't necessarily speak to each other. And they don't, not only do they not speak to each other, they often are adversarial in terms of sharing information. Where we see positive indicators of this, there are some, if you will, rather informal agreements between states. There are almost always states, though, that are close to each other on the map, and around cities that sit around a state line, right, where it makes sense to share in Kansas City between Kansas and Missouri, and more informally, right, because you have a very fluid place like that. But it's absolutely critical, perhaps most importantly, because what we know is that being victimized, especially having a substantiated case of child maltreatment, puts you at tremendous exponential risk for another incident of child maltreatment, right? So it doesn't go away because you move, right? The change of scenery doesn't do anything for your risk factors. In fact, it probably increases them because you're now in a place with fewer resources, fewer people you know, fewer programs that you're involved with, and it doesn't allow that new state to know what worked for you before, what services did you get before, what made a difference, what didn't work, right? So without sharing that information, we set ourselves backwards in terms of helping children in the country.
And a quick follow-up on the nurse-family partnerships. Do you have a cost-benefit ratio?
I believe I provided one in my written testimony.
Okay, thank you.
Thank you. I now recognize Representative Thompson from Pennsylvania for 5 minutes for your questions.
Chairwoman, thank you so much. Thanks for this hearing, and thank you to all members of the panel here for your testimony, your experiences you bring. Dr. Jackson, as on behalf of all my Penn State alumni, welcome to Happy Valley. We're sure glad to have you there. Welcome to the Penn State family. In your written testimony, you state that despite public health approaches and certainly the emphasis that we've all had to child maltreatment prevention, that national rates have not fluctuated substantially over the past 15 years. You also mentioned that the most recent reports show that the number of children investigated for child maltreatment has actually increased by 10% over the past 5 years, and that the number of proven child maltreatment cases has increased by almost 3%. I wanted to drill down a little bit and get your impressions of why that is. Are we just more aware of these issues than we were in years past, so we really didn't have a good benchmark in the past, an accurate benchmark in the past, or as reflected with some of your most immediate conversations of, we're not all reporting the same way? What are your thoughts on that, why that is occurring?
Right. So why do rates stay the same, or why do they change? It's a really great question, because it speaks to, I think, ultimately a question we want to ask about is what we're doing making a difference, and can they be reflected in the prevalence and incidence rates that we see reported? So we do know a couple of things. One, the public is much more informed about child maltreatment than it ever was before, to be sure. There's many, many ways we are getting more information. Public service information within our school systems, right? So we get more information about the types of child abuse, types of child maltreatment, so we're aware of those things. To my knowledge, though, the number of things like the mandated reporters haven't increased. So we don't have more people reporting, but we do have more people who are aware. And I know particularly in the state of Pennsylvania, where when lights get shone on a situation where they are concerned about a particular incidents of child abuse. Penn State, of course, experienced this several years ago. It tends to increase the knowledge base in that particular state. So we see rates of reporting in child maltreatment in the state of Pennsylvania skyrocket, particularly. So there's some sense that is based on education, right? There's based on information that you have given them some encouragement to share that. But also, to be clear, the risk factors for abusing your children, whether those are neglect, physical abuse, or sexual abuse, have also increased. The amount of stress that families are feeling, the amount of conflict that's present in the home, the amount of mental illness that parents are reporting, the amount of addiction that's present in this country are also contributing to those rates. And so as a clinical child psychologist, those are usually the things that I'm paying attention to, are those sort of active factors that speak to risk in the family, even if reports are also increasing.
Thank you. Mrs. Rose, thank you for your testimony, excellent testimony. And obviously, life can be challenging, there's no doubt about it. Adversity is kind of a part of life. From time to time, it comes in different degrees and shapes. That said, and with the experiences that you've had, how can families and parents build resilience to be able to deal with that? What are some of the, I love your lessons learned. They were excellent that you shared in your oral testimony, written testimony, but but what else can we do what can parents do or family do to build that resiliency?
Thank you for your question. So I think back in my written testimony, it's there to a time when I lost a daughter, and it was a really hard time for us. And so everything I had essentially been equipped with the tools in my toolbox, were just kind of out the window. And really the connection and all the work that had been laid up to that point with my children and spending time and building relationships with my family gave me that reason to move forward. And so when you ask about building resilience and how we can make families do that, is just through simple everyday actions, pointing out family strengths. So instead of pointing out, we're so sorry this happened to you, that's being empathetic and that's helpful, but this may have happened to you, but here's, not a silver lining, but here's what you're strong at as a parent. Here's the reason why you need to move forward. Here are some things you can build upon. So not dismissing the fact of things that they may need to work on, but really building on the strengths of things that they're good at and highlighting that.
All right, very good. Thank you. Thank you, Madam Chair.
Thank you, and I now recognize Representative Langevin from Rhode Island for 5 minutes for your questions.
Thank you, Madam Chair, and Ranking Member Comer. I want to thank you for holding this important hearing and for allowing me to sit in and question today. And I want to thank our panel of witnesses and thank you all for the work that you're doing to promote child welfare. Clearly, we all have a lot that we can do, and we rely on experts, of course, like yourselves who are on the front lines, doing everything you can to make sure that we're protecting our children. I'm proud to co-chair the Foster Youth Caucus with Congresswoman Karen Bass and several other co-chairs. I came to these issues years ago when I was growing up. My parents had welcomed many foster children into our home, and today it's a priority of mine. It's certainly helped me to be a better policymaker on these issues to ensure that every child has a safe and loving home. So I'd like to touch on a specific issue that I became aware of several years ago, sadly, as a result of a Reuters report. It's a frightening phenomenon known as unregulated child custody transfers, or UCT, also known colloquially as rehoming. And this is a practice of basically transferring custody of a child, usually an adopted child, to a stranger outside the safeguards of the child welfare system, resulting basically from a failed adoption. And I first learned about this about 5 years ago from a Reuters published report on parents who were advertising, if you can believe that, their children on online forums, often because they couldn't handle their child's behavioral issues resulting from past trauma. Without a system of support, these parents turned to strangers, people who hadn't undergone background checks, home studies, or supervision. Some children from the report ended up in homes where they were subjected to physical, sexual, or emotional abuse, not to mention the additional trauma and instability of a new placement. Addressing UCT, of course, requires a multi-pronged approach, including increasing support services for families so that they never reach the crisis point where they feel they need to give up their child. Again, it results in a failed adoption. Just as important, however, is the need for uniform national standards to identify for identifying and responding to reports of UCT. So instinctively, we know that UCT is a form of abuse and neglect, and yet on the federal level, in the vast majority of states, the law doesn't clearly treat it as such, creating confusion for Child Protective Services when they try to investigate cases and sometimes leaving them uninvestigated entirely. So I'd like to start, if I could, Dr. Jackson, with you. Based on your experience, can multiple home placements cause trauma for children? And do you agree that unregulated custody transfers, which often place children in unsafe environments, are a form of child maltreatment?
Thank you for the question. So the first part of your question is about multiple placements causing harm. So my answer to that question is it depends on the placement. If you are moving someone from a dangerous placement or risky placement or unsupportive placement to some other place that's supportive, then it's a good idea. And if that environment no longer meets the needs of the child, finding a place that does is a good idea. Now, that said, children need stability in their lives. They need that kind of basic foundation to be able to understand routine. So we wouldn't encourage it by any means, but I wouldn't give a blanket statement to suggest that multiple placements are necessarily problematic. It's all about the quality. This is true when it comes to alternative care in general. The idea of it is not bad. It's the implementation that can be problematic. It is the kind of home you get placed in. It's the support and environment that you're in now that makes a difference. And if that new place is not a better place and doesn't meet your needs, then you will continue to have difficulty. To answer your second question, unfortunately, I'm not familiar with this phenomenon that you're describing, this, if I understand it correctly, this having adopted kids and saying this is not working out, and then on your own as a family, finding another place and bypassing Child Protective Services. Unfortunately, I'm not familiar with that.
Okay. My time's about to expire, and I'll put this one for the record, but in your testimony, you mentioned the importance of coordinating efforts across the patchwork system of federal, state, and local agencies to prevent child maltreatment. How important is it to have clarity about what constitutes child abuse and neglect to this coordination to preventing and responding to child maltreatment? So I know my time's expired, so I'll yield back in view to answer that question for the record.
Thank you, Mr. Langevin. I see no other members to ask questions, so I want to remind my colleagues that pursuant to committee practice, materials for submission for the hearing record must be submitted to the committee clerk within 14 days following the last day of the hearing, preferably in Microsoft Word format. The materials submitted must address the subject matter of the hearing. Only a member of the committee or an invited witness may submit materials for inclusion in the hearing record. Documents are limited to 50 pages each. Documents longer than 50 pages will be incorporated into the record via an internet link that you must provide to the committee clerk within the required time frame, but please recognize that years from now the link may no longer work. And now, without objection, I'd like to enter into the record a report from the U.S. Government Accountability Office, which recommended that the Secretary of Health and Human Services strengthen the data quality of child abuse and neglect fatalities and current practices leading to incomplete counts. And a scholarly article written by researchers at the Centers for Disease Control showing that the total lifetime cost of substantiated cases of child abuse and neglect is $830,928 per child, which bears a total annual cost of $428 billion to our country. Again, I want to thank the witnesses for their participation today. What we have heard is very valuable. Members of the committee may have some additional questions for you, and we ask that you please respond to those questions in writing. The hearing record will be held open for 14 days in order to receive those responses. And I remind my colleagues that pursuant to committee practice, witness questions for the hearing record must be submitted to the majority committee staff or committee clerk within 7 days. And the questions submitted must address the subject matter of the hearing. And I now recognize the distinguished ranking member for his closing statement.
Thank you, Madam Chair. And our witnesses gave excellent testimony today on the importance of CAPTA. We know this is a critical law that helps states, local governments, and organizations save lives. We also heard that there are some improvements that can be made to improve the system and help the grantees better help families and children. Changes like looking at prevention programs, focusing on ensuring local programs can serve people in a way that works for them, and collaborating with stakeholders to improve services. I look forward to working with my colleagues on these improvements, and thank you all very much for your time. Madam Chair, I yield back.
Thank you, and I now recognize myself for the purpose of making a closing statement. Thank you again to all of the witnesses for being with us. We appreciate your expertise and experiences. Today's hearing was an important step towards strengthening our approach to child abuse and neglect. Although we've made progress in reducing some rates of child maltreatment, we cannot allow ourselves to become complacent, and we cannot allow the disturbing rise in child abuse and neglect cases to go unaddressed. This is not only a public health crisis, but a threat to the future of our country. Accordingly, Congress has the moral obligation to expand and improve the Child Abuse Prevention and Treatment Act for the new challenges facing our children, families, and communities. And we can all agree, regardless of party affiliation, that our current system needs improvement to make sure that children are protected from immediate and long-term consequences of abuse and neglect. And as our witnesses also reminded us today, any proposal to reauthorize CAPTA, the Child Abuse Prevention and Treatment Act, must recognize the importance of holistic solutions that prevent families and children from suffering, instead of waiting to treat children after they've been hurt. We need to make sure that state agencies can work quickly and collaboratively with a broad range of protection and support services for all children, no matter where they are. Everyone here knows what is on the line. We're committed to taking bipartisan steps toward a Child Abuse Prevention and Treatment Act that our children desperately need and deserve. And I look forward to working with my colleagues on both sides of the aisle to make sure that all children have a safe and healthy environment that allows them to reach their full potential. The lives and future of so many of our children and families are at stake. With there being no further business, without objection, the committee stands adjourned. Thank you. And I don't see too much difference in what we're all talking about, which is